Occupational English Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for extract 1. Extract 1, questions 1 to 12. You hear a cardiologist talking to a patient called Rosie Clarkson, who's been referred from the hospital's emergency department. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Right, so, Rosie, the emergency doctor sent me your details, but perhaps you could just tell me in your own words what's brought you here today.
Sure. Well, about 6 weeks ago in July, I noticed I was getting a sort of a dull ache around my shoulder blades. I do a lot of desk work, and I just thought it was because I was, spending too long in that one position. I didn't really think anything of it. But then we went out for the day last Sunday to a place by the sea. We often go there, but this time, when we walked up the hill to the lighthouse, the ache got worse and I came out in a cold sweat. I mean, I've never had that before, and it was strange. It seemed just to affect my hands and the soles of my feet. I also felt this really bad nausea. I've never had that before either. Anyway, my husband noticed that I was panting and puffing, which is unusual for me. Then both arms started to get this sort of tingling feeling. So anyway, I was a bit worried about this. I wondered if I'd got a bug or something, because I'm normally very fit.
Right. Yeah.
So on Monday, I went along to my GP. He had a look at me and he found that the areas where I was feeling the ache were a bit sore, so he thought it was probably some sort of musculoskeletal thing. But by this time, I was also feeling it in my chest. So he said just to be on the safe side, he needed to do an ECG. He did that straight away, and something wasn't quite right. So he said I needed to go to the emergency department. That's when I started to get a bit scared, really. Anyway, they did lots of tests, blood tests, a chest x-ray, blood pressure, and apparently everything was normal. But then they said I needed to have something called a stress test. I didn't even get to finish that one before the pain in my chest came on again, but this time even worse than before. They said that suggested something wasn't quite right, and there might be something wrong with my heart, that I needed to see someone about it straight away, so they sent me on to you.
Good. Well, I can understand this has all come as something of a shock to you, but I'm sure we can sort something out for you. How's your general health? You look pretty fit.
Yes, I get lots of exercise, horse riding every week and boogie boarding in the surf with my daughter. I don't smoke, and I check my BMI at the gym. That's 25, so fine. So's my cholesterol. I've never had problems there.
Any history of heart disease in the family?
None.
Excellent. And your family situation?
I'm married with just the one daughter who's 18 now. She's off to university this year. I love my job. I'm a reporter. It can sometimes be quite stressful, though. I've covered some pretty tragic events over the years. But I've always thought of myself as quite resilient. But actually, well, even before this latest problem, my self-confidence did take a bit of a knock because I had to have a mastectomy 4 years ago. It came as a bit of a shock. I just had a routine check, so I suppose I was lucky it was spotted in time, but it really knocked me for six, especially the chemotherapy afterwards. It took me a long time to get over it, not so much physically. It was more that it was lurking at the back of my mind all the time. I just about got over it, and then this happened.
Well, Rosie, I'm sorry to hear that. But it's quite possible that this is nothing to worry about.
Now, Mr. Parr, I can see from your GP's notes that you've been experiencing some unusual symptoms recently.
Well, yes, that's right. You see, it's come on gradually over the last few months. The pain, that is. It began in my hips and it slowly got worse. It soon spread to my lower back, mostly on the right side. I thought I'd just been working too hard and a good rest would sort things out, but I actually find it the opposite. It's much worse after I've slept and it actually feels better following a bit of exercise, which is hard to understand.
And is the pain still there in your back?
Yeah, but not only there, it's now pretty widespread. Makes me rather moody, to be honest, which isn't like me, because it's now on both sides and it's gradually gone into lots of different areas, like my shoulders.
Okay.
What's most annoying is it now hurts to walk sometimes, because it's even in my heels now, at the back of them, here. It's really quite tender.
I see. That must make things difficult. And have you noticed any other symptoms apart from the pain, I mean?
Well, I'm tired an awful lot of the time, and something strange I have noticed just recently is my eyes. I've noticed they feel pretty sore for some reason, and they're watery, too. And sometimes I can't really see properly. Things look quite blurred. I've lost my appetite, too. I just don't feel like eating half the time, and I used to be a really good eater.
And looking at your GP's notes from your last appointment, I see that she sent you for some blood tests?
That's right, and she told me the first one showed I had mild anemia.
Okay.
That could be why I've felt so tired these last few months, I guess. She said that the following test showed some inflammation, too, which she said was in the bowel. I think that might explain the loss of appetite.
And have you found anything that helps with the pain?
Nothing makes it go away for any length of time, to be honest. Though I do find that heat often soothes it, you know, heated pads and warm showers. But the pain always returns soon afterwards. Something which does seem to help a little is yoga. A friend of mine teaches it, so she showed me a few exercises to do. I mean, it doesn't get rid of the pain, but it seems to ease it. She suggested acupuncture too, which I tried, but I gave up after a few dozen sessions. It just wasn't making any difference at all. That was disappointing because it was quite expensive, actually. The same friend's just lent me her TENS machine, so I've started using that. It's a funny sensation, you know, the pads on my skin. And I'm not sure if it really helps or not, but I'll stick with it for the moment.
I see. And what about your family? Does anyone else have the same sort of problem?
Not that I know of. I mean, I'm an only child, and my dad died about 6 months ago. He had advanced lung cancer. My mum's pretty well overall. She even helps out sometimes with my work admin, which I really appreciate. I'm a plumber. I work for myself, and she knows how difficult it's been recently with this pain. It's affecting me quite a bit, to be honest. I mean, I still try to see my friends every weekend. We used to go 10-pin bowling, and I enjoyed that, but I don't go anymore. I can't seem to concentrate very well these days when I'm doing anything like that.
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a consultant talking to a woman whose father has just been admitted to hospital. Now read the question.
So we've talked about the various things that might have caused your father to collapse. A lot of times we investigate multiple symptoms so as to rule out any life-threatening conditions.
So it could take some time to get to the bottom of the problem.
Possibly. In the meantime, he's quite stable now, and we're encouraged by the progress that he's making.
Well, I'm glad to hear that. But at least he's not in any great discomfort, is he?
According to the assessment at the bedside by his nurse, his pain is well controlled, and we'll try to keep his sedation at an adequate level until we're ready to begin treatment.
Question 26. You hear a trainee nurse receiving feedback from her tutor about the ward round she's just completed. Now read the question.
How do you feel your ward round went with that patient?
Oh, I really should have told him what I was about to do, rather than just rolling up his sleeve to take his blood pressure.
Yeah, it would have been preferable, but at least you realise.
Thanks.
I think you did your observations really well, though. You checked the patient's details are correct, you put the date in, you timed it correctly, you observed that all your parameters are within normal range, and you did the respiratory rate while you were doing your manual pulse.
Yes, the pulse was quite strong and regular.
And you could have passed that on to reassure the patient too. But you look back at the previous observations, put your signature at the bottom. That's all good.
Thanks, okay.
Question 27. You hear a hospital nurse briefing a colleague about a patient with chronic obstructive pulmonary disease, or COPD. Now read the question.
So who's next?
The patient in bed 12. She had a fall at home about a month ago, but she's otherwise independent with her day-to-day activities. Her falls risk is high given her recent history. She's been assessed by the physio, and she's on a rollator frame to ambulate. Her skin integrity is intact, and she's responded well to all treatment.
Good.
She's on a normal diet. The observations were last done at 6 a.m., and they were stable. Her medications are IV tazocin due at 2 p.m. and prednisone next due at 8 a.m. tomorrow.
Okay.
You need to check with the doctors today whether she'll continue with the IV antibiotics and whether the cannula can be removed. At this stage, they're aiming for discharge in a couple of days' time, pending discharge from the physio and also ceasing IV antibiotics.
Okay, thanks.
Question 28. You hear 2 hospital managers talking about a training session for people who do voluntary work with patients. Now read the question.
So how do you think the volunteer training course went?
Well, we had a reasonable turnout, considering that these people already give up their free time to drive patients to appointments, visit inpatients, all sorts of stuff like that. It's quite a lot to ask. It's a wonder so many managed to fit in the training too.
And they did seem to get something out of it, if the feedback sheets are anything to go by. From my point of view, though, I just wasn't sure whether it went into issues like customer care, confidentiality, that kind of thing, you know, in enough depth.
Well, that's something we can always look into before we roll out any more.
Well, I think we should.
Question 29. You hear a pharmacist talking to a doctor about a patient's medication. Now read the question.
Sorry to bother you, Dr. Baker. I just wanted a quick word about Mrs. Milton's prescription, the one for anti-inflammatories that you gave her after last week's consultation.
Oh, yes, for her osteoarthritis.
Yes, so she's been on them for a week now, 500 milligrams twice daily. The thing is, she's just been into the pharmacy complaining of a headache ever since she started the medication.
Really? Well, that does happen in some patients, but maybe switching her onto a different anti-inflammatory wouldn't be a bad idea.
OK, I'll look into some options and then run them past you later, shall I?
Fine, thanks.
Question 30. You hear a surgeon talking to a member of his team as they are finishing a surgical procedure. Now read the question.
Good, there's no more bleeding. The procedure's finished.
Can we just do the sign-out? How much contrast did we use?
That was 120 mils of Omnipaque, and we did reach a high dose, so I'll have to fill out a high dose form. I'll do that afterwards. The other thing was that the ultrasound machine was giving us a few problems.
Yeah, I'll have to get the technician on the phone.
Do it now, though, because we'll need it if we're going to get through all our lists today.
Do we need to send this patient up to HDU?
Actually, everything was quite straightforward, so I'd say a regular ward bed is fine.
That is the end of Part B. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You hear an interview with Dr. Bob Dean, who's talking about a trial he conducted to assess different ways of treating the condition known as tennis elbow. You now have 90 seconds to read questions 31 to 36.
The condition, commonly called tennis elbow, is a painful condition of the tendons which interferes with tasks involving gripping and manipulating objects. A recent trial led by Dr. Bob Dean has tried to see what type of therapy works best. Bob, is there a typical way that tennis elbow starts?
It's a very common condition, but apart from tennis players themselves and people working in industries where they do certain manual tasks, it's surprisingly difficult for patients to pin down the actual start of the pain. And even with those high-risk activities, it's generally something that comes on over a period of time. In tennis, it used to be said it was down to the player's grip or the type of racket they were using, but nobody's really researched that thoroughly. There are plenty of guidelines out there, but they're not evidence-based. When somebody has pain, then modifying their tools, whether that's a tennis racket or something at work, may well help, but that doesn't necessarily mean there's a causal link.
So what was your approach in the trial you conducted?
Well, we divided our patients into 3 groups. One group followed a physiotherapy program, another was asked to do nothing to see if the condition just went away by itself, the wait-and-see group we called them, and people in the 3rd group were given steroid injections. The physiotherapy we used was a specific elbow manipulation. The therapist applies manual force to the elbow joint, and at the same time, the patient actually performs the kind of task that causes the pain. The aim is to apply the force in a way that relieves that particular pain. But just as important is the physical activity the therapy calls for, because in most tennis elbow patients, their muscle system's quite debilitated.
And I understand that complete rest wasn't seen as an option? Instead, you described something called smart rest?
Resting's an interesting thing. Immobilizing the arm in a sling is probably the worst thing anyone with tennis elbow can do. In fact, resting most muscular-skeletal pain isn't good. What we advocate is something called smart rest, and what this means is being as lively, as dynamic as possible, but not hurting the elbow. An example is where patients avoid picking things up with their palm facing down, which is classic advice given to anyone with a condition. But patients do need the stimulus of movement to help rehabilitation. And so all our participants were given advice on how to manage their condition ergonomically, even the wait-and-see group. The difference was they didn't get any other form of treatment, whereas our other 2 groups did.
So what were the results?
What we found was that steroid injections were more effective in the first 6 weeks, but not after that. The physiotherapy group also reported good results at 6 weeks, comparable to those for the injection group, and much better than those reported by the wait-and-see group. But then, after 3 months, the situation had changed. The physiotherapy group was now reporting better results than the injection group, and, remarkably, so was the wait-and-see group. Indeed, they were catching up all round, so much so that after 6 months, physiotherapy is no more effective than doing nothing. At 12 months, and what's fascinating is that we're the 2nd study to show this, the recovery rate for people who do nothing was 70 to 80%.
So what does all this mean for patients? What advice would you give them on the strength of this trial?
I'd say, in the first instance, rest the elbow and see how it is in 3 months. If it hasn't resolved itself by then, they're probably one of those 20 to 30% who aren't going to get better. At that stage, I'd recommend they have some sensible physiotherapy. I don't think there's much evidence to support the use of steroid injections until a really good attempt's been made with the wait-and-see approach backed up by physiotherapy. But it's still worth trying at that stage because the alternative could be some quite drastic measures, even possibly surgery.
I see. Now, it's quite common for people to think that if something's sore and swollen, they've got to take anti-inflammatories like ibuprofen. Are they right?
Well, there have been various studies about this, and what they've found is that there's little evidence of inflammation in tennis elbow. So there's no reason to think that non-steroidal anti-inflammatory drugs are going to be very beneficial. So I suspect that just taking basic over-the-counter pain relief would be at least as successful as taking anti-inflammatory drugs, in the case of tennis elbow.
questions 37 to 42. You will hear a plastic surgeon called Norma Woolston giving a presentation about surgical treatment for a condition called Dupuytren's contracture. You now have 90 seconds to read questions 37 to 42. My name's Norma Woolston, and I'm talking today about surgery for a condition called Dupuytren's contracture, with a particular reference to a case I treated recently. Dupuytren was first described by a French physician of that name in 1834. It's a condition in which one finger becomes increasingly bent in a flexed position. The first sign is a formation of small hard nodules in the palm of the hand, but early diagnosis is relatively unusual because there is no associated discomfort. In its early stages, the condition may respond to steroid injections and physical therapy, but this doesn't necessarily halt its progression. The affected finger often becomes increasingly bent and can no longer be straightened. But patients tend to present with the condition only when manual dexterity is compromised, by which time surgical intervention is indicated. My patient, let's call him Eric, presented with quite an advanced case of Dupuytren's affecting the little finger of his right hand, a relatively common site for the condition, although a physical examination revealed that he was also developing the first signs in the thumb on the same hand. Eric was then a 61-year-old office worker who used a keyboard regularly. There isn't very much published so far on the causes of the condition or what might exacerbate the symptoms, but the digital age doesn't appear to have resulted in an exponential rise in the number of cases reported. Eric was finding the condition inconvenient and uncomfortable rather than painful. It was becoming tricky shaking hands with people, and holding a pencil was becoming a challenge. Eric didn't recall any family history of Dupuytren's. That's not unusual, but doesn't in itself mean that there was none. Indeed, we know that the condition is often present across the generations of one family. But because patients don't typically develop symptoms until late middle age or later, it often goes undiagnosed, or doesn't develop to the point where it requires treatment. Indeed, mild symptoms are often attributed to mild arthritis or the general effects of aging and wear and tear. Nor did Eric report any of the other associated risk factors, such as smoking, diabetes, or low body mass index. It's worth noting, however, that he was of classic Northern European appearance, tall and fair-skinned, and Dupuytren's is known to be much more common amongst Northern Europeans than in other populations. In Eric's case, the condition had progressed to the point where surgery was indicated. It was clear to me that what was required was a fasciotomy to straighten the finger. Eric had some misgivings about this, as he'd heard about less invasive treatment options. But I explained to him that taking into account the extent of development of the diseased tissue and the specific site, this was the only option, and he agreed to go ahead with the procedure. Fortunately, Eric was generally in good health, was taking no medications for other conditions, and had no concerns or negative history relating to general anaesthetic. This was much the preferred option because, although the surgery isn't lengthy, usually between 30 and 40 minutes, it does call for a complete immobilisation of the hand. After the procedure, Eric was using a sling and pillows at night to hold the wound site high up and so prevent a build-up of fluids. I'd explained that wearing a sling when out and about also provides a degree of general protection. It's a remarkably effective way of signalling to other people to keep their distance, as the hand is very sensitive to knocks. But actually, he'd taken plenty of time off work, so this hadn't been a problem for him. Indeed, when I saw Eric at the follow-up appointment, the wound was healing well. His notes showed, however, that the sutures hadn't all fully dissolved after surgery, and that this had been a source of discomfort. Worried that perhaps there was an infection, he'd consulted a nurse, who'd removed them and also taken the opportunity to excise some excess scar tissue, which had formed at the site. I reassured him that this was by no means unusual and wasn't a cause for concern. I was pleased to see that when he returned for the final consultation, Eric's wound had generally healed well. As is the case with many Dupuytren's patients, however, Eric volunteered that despite my careful explanation at our first consultation about the treatment and recuperation period, he'd entirely underestimated the impact of the surgery on his daily life and how long the disruption would continue. That said, his finger is now much straighter. This treatment for Dupuytren's never completely straightens the finger, nor restores full use, but he'd been aware of that from the outset and had no complaints on that score. So far, apart from the initial indications in his thumb, there is no sign of recurrence, although this is relatively common, especially over time. I reflected, however, that perhaps being very familiar with the condition and having performed this kind of surgery many times, I hadn't made it clear enough to Eric exactly what to expect after the surgery. What Eric's case made me realise